afternoon. Welcome, everybody. My name is Richard Snyder. I am the director of the Center for Latin American and Caribbean Studies here at Brown University. And it's a pleasure to welcome you to this very timely panel discussion about the Zika virus. This is a pressing issue of public concern, and it involves the region, Latin America and the Caribbean, which the center focuses on. So it's very appropriate for us to be holding this event. Since the Zika virus burst into the media and public's attention over the last month or so, with the World Health Organization declaring it a global health emergency, there's been a lot of attention and a lot of interest in Zika. Latin America has been an important focal point for this attention, with increasing reports of active transmission of the virus. Brazil, in particular, has been at the center of much of the interest because of the large number of reported transmissions, and also because Brazil will be hosting the Olympic Games this summer, and hundreds of thousands of foreign visitors, including many from the United States, will be going. Many of the other countries in the region where Zika is currently active are also important, especially for Rhode Islanders, as travel destinations and also as places where citizens of Rhode Island have family. This includes the Dominican Republic, Puerto Rico, Guatemala, Honduras, Mexico, and Colombia. Also, Brown University is a globalized university, and our university community, we have lots of connections and lots of travel back and forth between countries in the region where Zika is active. So what CLACS, the Center for Latin American Caribbean Studies, is doing, we're organizing two panels actually about the Zika virus. This is the first one. Today, the panel will focus on medical science and public health knowledge in an effort first to separate facts from fiction about Zika, and also to give us a sense of the kinds of public policy responses to Zika that make sense and that are validated in terms of medical science and public health knowledge. The second panel will be held here in this room on Wednesday, March 2nd at noon, and that will focus on, not so much on the problem, so to speak, of Zika, but on some potential solutions. And we have some experts from the biotechnology community coming to talk about things like genetically modified mosquitoes as a way to combat the Zika vector, as well as developing vaccines. Okay, so if you're interested, please come to that event as well. And today we have with us a distinguished panel of experts on infectious disease and public health. And I'm going to introduce, we have fourth person may show up shortly, but we have three here. So I'll introduce, I guess, all four of them in the expectation that the fourth will show up. And then I'm going to ask them each to give brief presentations, about 5 to 10 minutes, and then we'll open things up for your questions and for some discussion. So I will introduce them starting on my left. We have Dr. Maria Mileno with us. She's an infectious disease specialist with a special interest in the area of travel and tropical medicine. She's also an associate professor of medicine at the Alpert School of Medicine here at Brown University. And Dr. Mileno has helped direct the travel clinic at the Miriam Hospital for many years. Next, we have Dr. Rebecca Reece, and she serves as a medical consultant for the Rhode Island Department of Health's Division of Preparedness, Response, Infectious Disease, and Emergency Medical Services. Dr. Reece is also an assistant professor of medicine in the Division of Infectious Diseases at the Alpert School of Medicine here at Brown University. And then next we have Mark Lurie. Dr. Lurie is an associate professor of epidemiology. He's an infectious disease epidemiologist, and he has conducted research on HIV and AIDS, as well as other sexually transmitted infections, tuberculosis, and silicosis in sub-Saharan Africa. And then last, we hopefully will have today with us Dr. Brenna Hughes, who is the chief of the Women's Infectious Disease Consultative Service at Women and Infants Hospital here in Rhode Island, and also an associate professor of obstetrics and gynecology at the Alpert Medical School of Brown University. So I believe the order panelists would like to proceed in is we will start with Dr. Reece, and then if Dr. Hughes arrives, we'll go to her. If not, we'll go to Dr. Lurie, and then finally to Dr. Mileno. So Rebecca Reece, welcome.
All right. Hello, everyone. Thank you for having me here this afternoon. I'm going to just give a brief little bit of background on Zika and kind of the things we do know about Zika, and then the questions that are raised and to why policies have been made based on those questions. So first thing, Zika is not new. The thought this is a new emerging infection is not true. Zika has been around since the 1940s. Now, it is new to the Americas since 2015 in May when it first started out in Brazil. But we've had cases of Zika here in the US from travelers to Asia before, so it's not a new infection. That being said, we have a lot of infections spread by mosquitoes, so we know that these outbreaks can happen. Just 2 years ago, chikungunya came up as a new emerging infection. Emerging, yes, but not new. So that's one caveat. These are not new infections. These are just emerging as they come now into our region and to more outbreaks. The other thing about Zika, unlike Ebola, we're seeing a lot of news about Zika. Unlike Ebola, this disease is a mild illness in the vast majority of people. It only causes symptoms in 1 in 5 people who are infected. So let's take that to heart when we're starting to get panicked about Zika. Only 1 in 5 show symptoms, and of those symptoms, they're quite mild. They are a rash, maybe some joint pain, maybe fever, usually only last about a week. So the symptomatology of it is mild. It mimics other infections, but it is not very virulent. So if we think about other infections like Ebola, where it's quite high mortality rate, this is not the case with Zika. It's a self-limiting viral illness. The problem that we have now with Zika, as we've seen in 2015, is that we've seen a rise in cases of microcephaly among infants, mainly in Brazil, but other countries as well, as we've seen the rise in Zika infections. Now, has that correlation been completely proven? No, it's just a rise in both at the same time. So there's a suggestion that there is a link there. And so that's concerning, of course, for any woman who is pregnant or maybe become pregnant. And so that is why the policy of travel advisory to this region of the world for women who are pregnant or could be pregnant is given. The safest way to prevent yourself from being infected with this virus is to not travel to regions of the world where it's at right now. And at this time, it's in the Americas, South America, and Central America. So that's that policy. It's not a ban on travel to that region. It's saying if you are pregnant, if you want to take precaution, try and postpone your travel if at all possible. And if not possible, use mosquito prevention techniques. So that's one of the questions still we're waiting to figure out is there a direct link to microcephaly from this virus? And hopefully Dr. Hughes will be here to speak more about that, and more research will come to let us know. The second big question about Zika is transmission. We know it is a mosquito-borne infection. We know that it can bite someone infected and then transmit to another person through that mosquito bite. So it can be transmitted that way. When you have virus in your blood, it can be transmitted by blood to blood. So we do recommend that if you have traveled to that region, you wait 28 days before you donate blood, just to lower that risk of transmission. But other ways of transmission has been proven so far with sexual transmission, with 2 reported cases, and also finding that the virus can stay in the genital tract region for at least 2 to 10 weeks. We don't know beyond that. So that is why we give the advisory about sexual activity among women who are pregnant, may be pregnant, or want to become pregnant. They should avoid unprotected sexual encounters with any of their male partners who have traveled to that region of the world until we know more about how long it can be transmitted. So the CDC, that's another unknown we're still waiting to see. And so this is why the CDC has made this the highest emergency ops level as of yesterday morning, I believe. It's only the 4th time in history the CDC has given this a level of priority. The other 3 times were Hurricane Katrina, H1N1, which is swine flu, and Ebola. And so there is a question, why is this high priority where there's very low virulent factors along with this virus? Well, one is to prepare ourselves. The mosquito that carries this virus also comes into the US in the lower states. And so we need to prepare ourselves as that warm weather comes. The second thing is to find the answers to these questions. Is it a direct link to childhood microcephaly in these infants? Is there a direct correlation to that issue? And so we need that research. So that's why the CDC has asked for this funding. That is why there's a high priority, is to try and get those answers, as well as to figure out how we can help curb the mosquitoes and mosquito-borne infections. Because if Zika is a concern, we also have to raise the question of dengue and chikungunya and all these other infections. So there's a lot of questions out there, and that's why we have that priority. So it's not our priority because we feel like this disease can be quite harmful to a population at whole, certainly to a certain group of our population, the pregnant women, but also because of the proximity to us here in the U.S.
I actually have a few pictures. Addicted to PowerPoint, what can I say?
Hi there.
Do you want to get settled, or
Sure,
if you
I'll
want
get a
to
little
speak?
settled.
Okay, fine.
That's great.
We're very happy that you're here because
Thank you. Ultrasound went
none
long
of us,
today.
I think, are experts in perinatal infections, and so we certainly need that expertise.
Great.
I guess I just want to make a few disjointed comments, but start by saying I think there are going to be as many we don't knows as there are we do knows in this forum today. I think we're at the very, very early stages of understanding the critical aspects, from my perspective as an epidemiologist, the transmission dynamics, the period of infectivity, the rates of infection. These are the kinds of questions that are critical to understanding whether and how epidemics are going to spread. And in this particular case, we have more unknowns than we do knowns. What we do know is that the upsurge, if you look historically at where Zika has been, we've already mentioned the early and first places in the mid to late 1940s, really confined to Africa until the 1970s with a quick jump to Malaysia. But it's really in the last year or two only, and very recently, that it's become that it's migrated over through a quick jump in French Polynesia over to Brazil and to the Americas. We have an emerging epidemic, one that's relatively new and one about which we have as many questions as we do answers. What we do know is that the range of the mosquito that spreads, that's mostly responsible for spreading this disease, has been essentially, has had a history of coming and going, largely as a result in the 1970s. You can see almost an eradication in many parts of South America as a result of, for the most part, house-to-house spraying and detection of places where the mosquito breeds, and those basic primary prevention activities like protecting yourself by using insecticides, wearing long sleeves, and limiting exposure to the vector. These are sadly still the main tools that we have for prevention of Zika, of malaria, and other mosquito-borne, and most of the other mosquito-borne viruses. So we still have a lot to learn. What we do know is that through some mechanisms, at least temporarily, you can get close to eradication, but when you let up on those efforts, you get what you see in the more recent years. What we also know is that Zika, like many of the other infectious diseases that we've seen emerging just in the last couple of years, Ebola, SARS, are some of the examples, is that many of these infections are perfectly suited for spreading, for global spreading. In fact, what I'm trying to say is the other way around, is that our society, in particular, the interconnections, the globalization, the travel, the rapidity with which an infected person can get on a flight in one part of the world and be still in the infectious phase and land in another part of the world is, something that has changed within the last few years. And the New York Times represents this very nicely with their link between places in the United States and those places where we've already seen transmission of of Zika virus. I think our colleague is very right. We probably wouldn't be talking about Zika here at all if the microcephaly issue wasn't an issue here. It's been around. It causes, very minor symptoms for the very small majority of people who actually experience symptoms. As we've said already, about 3/4 of people are asymptomatic. But there's still major issues that we need to answer. CDC thinks that these are the potential risk areas in the United States. They're really, I think those colors are not showing very nicely, but really the southern states are the potential high-risk places in the U.S. Let me just make one more point. I've tried to speak about the global interconnections that are conducive to the spread of infectious disease, and I think we're seeing that in this particular case of Zika, as we're going to see in future new infections that we don't even yet know. And because I can say that because we've seen that amongst infections that have happened in the recent past. I think another thing that's worth talking about, and again, I'm not an expert in this area, but the degree to which environmental changes are related to the emergence of some of these infections, and certainly Zika would be an example of that. So, for instance, the global climatic changes that are occurring are leading to different and increased distribution, global distribution of the vector of the mosquito that's causing these diseases. Not only that, but with a small rise in temperature, the WHO predicts a small rise, just a 2 to 3 degree rise in temperature would lead to about 3 to 5% increase in the entire population, global population, being susceptible to malaria. That's roughly on the order of several hundred million people. So changes in global temperatures, environmental changes are leading to changes in the and increased zones in the vector that are responsible for some of these diseases. And finally, I think it's worth pointing out that some of the unintended consequences of development are also responsible here. Some of the dams that we've built, some of the changes that we've made to the ecology have had some unintended consequences at times of allowing for breeding grounds, in this case of mosquitoes, of the larvae that are those that are infecting us with Zika now. So I think there's some responsibility to be placed in that arena as well. So with that, I'll pass on to my colleagues.
Great, thanks so much for having me. I apologize for my tardiness. I was in the ultrasound unit and we were running behind. So I'm a maternal fetal medicine physician, just as background, and I did a fellowship when I did my high-risk fellowship also in reproductive infectious diseases. So I'm generally the person that people call when there's an infectious disease in a pregnant woman, and that's where my research focuses as well. Last week I was at the Society for Maternal Fetal Medicine, our big national meeting, just happened to be last week by coincidence in Atlanta with the CDC. We gave a couple of talks because just by happenstance we had everyone there together. And so for us in the maternal fetal medicine world, the big news was what came out on Friday, which is this MMWR, which is essentially requiring that all pregnant women in the U.S. who have traveled to a Zika-infested area will now both have serology as well as ultrasounds. And so that basically rocked the world of all of the maternal fetal medicine docs. And so there were about 1,000 people at one of these talks, trying to figure out how we are going to implement this in our country, because we really do not have the infrastructure to do it yet, despite the fact that these guidelines are out. And so just a little bit of background, I'm sure that this is a bit repetitive, but this is sort of the way we think about it from the maternal fetal medicine point of view, is we do think that there is an association between Zika virus and microcephaly. It is not yet clearly causally related. I'm sure someone else has said that before me. And after acute infection, though, Zika has been detected by PCR in blood of patients who are symptomatic. A major problem with the Zika virus is that the serology cross-reacts with the other flaviviruses, such as dengue and yellow fever and chikungunya, which makes the serology, when you're someone who is trying to do prenatal diagnosis for babies, very difficult. And as was mentioned, the mosquito is present throughout the Americas. What we do not know is could fill many more pages. That is, how likely is a person who gets stung with a mosquito that carries Zika to actually get it? So what is the attack rate? What is the incidence of maternal fetal transmission? So if a pregnant woman gets the infection, how likely is she to transmit it to her fetus? For other infections, we have pretty clear knowledge by trimester. For example, with cytomegalovirus, we know that by trimester, infection increases, the likelihood of transmission increases with each trimester, and the severity decreases with each trimester. We have no idea if that is the case in Zika. We also don't know whether there is an asymptomatic state in a fetus. So is it possible that mom could have the infection, pass it on to the fetus, and the fetus could get it and be just fine? That is unknown. As well as the causal relationship. We don't know how Zika virus causes microcephaly. If it does, whether it attacks neural tissue specifically, and therefore the heads and brains don't grow. That's unclear. As well as the magnitude of the risk that microcephaly might have on other adverse pregnancy outcomes. Are people more likely to deliver preterm? Are they more likely to have other adverse outcomes? And then the full spectrum of phenotypes in those affected fetuses, as I mentioned. We also don't know the immune response, the peak and duration of response. So the IgM, we don't know how long it stays positive. We don't even know how sensitive the IgM test is for if someone actually has the infection, how likely is IgM serology to pick it up, as well as the cross-reactivity issue. There is no IgG test even available yet, and so how is this test going to perform on people who are asymptomatic? We don't know. And I think I won't go through all of this detail because this is about cases and walking through the CDC algorithms, which most of you probably do not care about. But I'm certainly happy to do that. If people have examples, I can walk people through the algorithm. The only other thing I will say is the infrastructure here in Rhode Island is sort of our next big step, and we don't have it sorted out yet. I'm hoping by later today we'll have some sense with working with the Department of Health as to how we are going to do the testing for our pregnant women in the state. But that is sort of our big hurdle for our next steps. So I'll just stop here and then we can talk, I guess.
So just to echo some of the comments, this is a tropical disease, but it's not a new disease. It's a mild illness. In the patients I see in the travel clinic, people are coming very healthy and wishing to embark on places to, work and study and have a good time. And we've asked that pregnant women. Can you hear me better like that? Okay. From our clinic, we have told pregnant women either not to travel, basically not to travel to the Caribbean or South America or Singapore at this time. It's just not a good time to risk such a thing. There are many unknowns and uncertainties. What I find most interesting about this virus is how travel has prompted its island hopping, essentially, that it's the travelers who very likely have brought this to Brazil. At one point, people thought, could it have been from the World Cup that everyone went into Brazil, and yet Zika being more of a problem than losing to Germany, that this essentially could have been transferred. But it turns out that the people who visited for the World Cup really didn't come from Asia. So there was another race, this world sprint canoe race, where many people from French Polynesia, New Caledonia, the Cook Islands, all came and converged in Rio to have that race. And most likely the infection was caught during that type of exposure. So my role in travel medicine is to help people get where they want to go. We want to facilitate travel. There have been businesses who have called and said, well, we'd like to reroute our trip. Many men are concerned, will they come home and bring the virus to their pregnant wives or others? And lastly, of people who return with illness, my concern is, again, we do have the Aedes albopictus right up to the area of New York City, that in the warmer months, we could possibly have transmission of the Zika virus through those mosquitoes, not just the Aegypti. My bet is that Florida will be the first place to have local transmission because of the stagnant water and the Aedes mosquito. And so surveillance is of utmost importance to me. I've been somewhat restricted from my ability to test for this virus because the Department of Health has made it pretty clear they want to only test pregnant women. But I would love to know the scope of this infection in people who return, with illness. And if there's any way to write a grant or, have a more active role in thinking about the surveillance, I think it would be very important to map this out now. I've been a member of the International Society of Travel Medicine, where people come together from all over to think about these issues. And of course, the American Society of Tropical Medicine and Hygiene has made a stance on this and really focuses on how difficult it is, not for the pregnant women here in this country with resources, but think of the women in the poorest parts of the world who are 14 and have no recourse and no reproductive rights, no resources for preventing pregnancy or other things. It turns out this disease is somewhat linked to poverty. The well-to-do areas of Brazil have not had any Zika issues. But the areas most hard hit are the places with overcrowding, stagnant water, and few resources, I should say. So I'll leave it at that. I think there have been states of emergency placed in now Florida, but also Hawaii today has a dengue outbreak. And so each mosquito, the mosquito can carry the other very similar viruses, dengue and chikungunya, which have far more health impact, and therefore using the repellents to travel anywhere that these viruses exist is very important. And we go over in very great detail how to use proper repellents that stay on your skin and clothing. There are some myths out there about DEET. I'd be glad to expel those. In the interest of time, I'd like to hear what everyone has to say from the audience or ask. Questions?
Thank you very much to all of you. That was a great and diverse sort of set of perspectives on this problem. I want to open it up for questions. I want to take the opportunity to pose the first question in my role as chair. So the question is, I know that a number of Latin American governments have been advising women to hold off on getting pregnant if they're able to for several years in one case. And I'm just wondering, in terms of the public health knowledge and medical science knowledge about the disease, if that is a sound recommendation or not. And I ask that because thinking forward to the warmer months in this country and the possibility, we'll see what happens, that active transmission will be occurring in the U.S., I could imagine similar propositions coming forward in this country. And I just wonder what the medical science would tell us about that. So let me pose that, but I also want to take a round of questions from others. So let me take, let's take 3 or 4 questions, collect some, and then give the panelists a chance to reply. Yes, over here.
So Zika is not new to the world, but it seems that now there's a relationship, I'm not sure what you want to call it, with microcephaly. Was that the case when it was appeared in Africa? No. So then my next question is, has the virus mutated? Is it a different virus that can, I know you're saying it's not a new virus, but if we're associating it with something we've never seen before.
They describe that there are two sort of different strains, the African strain and the Asian strain, and the one in Brazil is of the Asian strain.
And they
these
have
are,
not
when they
seen-
looked back at the outbreak in French Polynesia, the Yap Island, they looked back and found other cases of microcephaly.
Oh, they have.
But only in retrospect, it wasn't
Yeah,
really
it's-
brought forth.
It's unclear how, again, whether there was an association at that point, but what they did see was amniotic fluid. There were tests of amniotic fluid that were positive during that outbreak, which is quite unusual.
Okay, let's take two more and then give everyone a chance to reply on the panel, if that makes sense. Yeah, down here.
With the Rhode Island recommendations for serology and ultrasounds for women, are there any clues? I know you said we won't know for a couple of days. Is this going to be a service that's provided free to all women, or are insurance companies going to be responsible? Have insurance companies offered to pay? What is the financial mechanism for serology and ultrasound testing, both of which can be quite expensive?
Great, thank you, Madeline. And let's take one more and then go back to the panel. Yes, back here. Wait 1 second to the microphone. There we go.
So the travel recommendations for pregnant women, and I guess by assumption as well their spouses, to Brazil and to parts of South America have been very clear. But I'm wondering about travel recommendations to areas where the Zika virus has been shown, Austin, Texas, or parts of Florida, for pregnant women and their spouses.
Great. We'll take one more and then give everyone a chance. Okay, yes, right here.
I didn't hear any of you mention transmission through saliva, and that's come out in the news the last few days. Can you comment on that?
Okay, so let's respond. What order would you like to go in?
So I'll-
You want to do the
I'll
saliva?
speak
since
to
we
the
don't know
saliva
symptoms?
and to a bit of the travel advisory. As far as the saliva, it has been found, so the virus shedding, in addition to, it's in the blood for at least 7 days, or 7 days is what we think. It's shed through the genital tract. We have found it in urine as well as in saliva. There have been no cases, though, of transmission through saliva that have been documented. Now, part of that is that we haven't had an outbreak to this level, and how would you very well know that unless someone comes back who's never traveled there and all they did was kiss, but it's never been shown yet. Again, that's where more research needs to be shown, is what's the viral load in the saliva compared to the genital tract. As far as the travel advisory, two things. So one, as far as why we haven't yet given travel advisory into the U.S. is, yes, the mosquito is in these areas of the U.S., although not quite out right now, per se. And second, the mosquito problem is much more prevalent in places of poverty, and so where we don't have very good mosquito techniques for prevention. In the U.S., even during the warm months, though we do expect some local transmission, we do expect it at a lower level as compared to these countries because we do have air conditioning. We don't have a lot of stagnant water. There's already preparations going out into the southern states to start do spraying for mosquitoes and that sort of thing. So we just have more resources here to try and keep the mosquito levels down. In addition, each state also does mosquito trapping throughout the summer months or fall or spring to fall. In the Rhode Island, we do that as well. We look for West Nile and Eastern equine because that's what we most commonly see here. But these states will be doing that and looking for Zika as well. I was going to answer one more question, but now I forgot. So.
As far as the pregnancy, and I think it's like asking the sun not to shine to ask women to not have babies for 2 years. It's in Latin American countries. That's I don't know how you would.
Agree. And the CDC has come out pretty strongly saying that they do not agree with that recommendation and do not support that recommendation.
Did anyone else want to?
I can address some of the other questions too.
please.
Sure. So relating the saliva, just in addition, it has also been found in breast milk. And the CDC is still recommending breastfeeding with the thought that likelihood of severity of disease, even if it is transmissible, is probably outweighed by the benefits of breastfeeding. And regarding the local transmission, the travel advisories, I think the travel advisories are mostly restricted to areas where there have been local transmission. And so even in Florida, the transmissions have been in travelers. There's been just the sexual transmission in Texas in the US that I know of that's been documented as true local transmission. And so for that reason, they have not altered travel recommendations for the US yet. I'm sure that will be coming at some point. And then regarding the serology and ultrasound and insurance coverage, it's actually a huge problem for people like me because we need to develop a mechanism for patients to come in for testing. In Rhode Island, thankfully, all pregnant women actually have insurance or can get it retroactively if they don't have it yet. And so we actually are developing codes with insurance companies, et cetera, ICD-10 codes for coding for serology and ultrasounds. Right now, we're using other viral illness, but that they will likely develop another code related to that. And so this should all, at least in Rhode Island, be paid for. I don't know the level of impact that it could have in other states that don't have the benefits that our patients do.
Mark, did you want to?
Well, I just want to caution against over-reading into the presence of the virus in saliva and other bodily fluids, because that doesn't necessarily mean that it can be transmitted in that way. Presence of the virus may be detected at very, very low levels, and higher levels may be required for transmission to happen. So don't equate the presence of virus with necessarily with transmission. So I think we need to be careful about that. The vast majority, if not all, of the transmission that's occurred to date has been from a direct bite of an infected mosquito. So that's the mode that we're obviously most concerned about.
Great.
Yes, we just don't know the significance of those body fluids, and there's a lot that's unknown.
So as we try to advise our employees about how to protect themselves in other countries, here in the U.S. we have pretty sound mosquito repellent, DEET or whatever. Maybe you want to go into some of those best practices. But once you get outside the U.S., how do we advise them where to look for the right protective measures to take? What's the right spray? What's the right, best practice in that region?
Okay, let's collect a few more over here.
Could you tell me about your knowledge of the work being done on recombinant vaccines? There are a couple of companies, one here in Rhode Island, one here in Connecticut, that have really done a lot of work with vaccines on demand. And BARDA is very interested in that, so I was wondering whether there's a way to produce vaccines much more quickly and more effectively against things like Zika.
There's a question two questions, one and then two. Yes?
So I would like to ask, what is the effect of pesticides on unborn babies, and is it possible that by widespread spraying we could do more harm than good?
Let's take one more.
I'm going to forget the questions.
Curious how the focus on Zika and the resources that will be devoted to this might be taking away from resources towards fighting malaria or dengue or yellow fever, and whether some of the things there might be in common, the research to combat these other diseases that affect tens or hundreds of million people a year in some of these same areas and around the world.
Let's turn back to the panelists.
Comment just on the last, in reverse chronological order. The first is that the more research we do about all of those diseases kind of dovetail together. So having knowledge of how to reduce the number of insect exposures, whether we could use insecticides safely is a question. However, there have been studies that show if you put DDT on walls, that doesn't necessarily pose an impact on a person who's living in their household. It's not the same as aerial spraying of an entire region. There's degrees of what we may be able to do and not be considered to have toxic levels. And to the point of the insect repellents, there are certainly some products that are better than others, and some that were quite dangerous and were taken off the market. So for example, there was a 100% DEET product that many people used to use, thinking 100%, it sounds so great, it's the best one, but it had the propensity to just evaporate into thin air, and also it would get absorbed into the body. And mothers who took their small babies in an overzealous way and put it on every inch, those babies had seizures, and you could find the DEET in the urine, that it passed through the body. We now have other products that are quite safe, that have, polymers that keep the drug right on the surface of skin, so that they're not deeply absorbed or toxic, and you could apply it and also count on it for 12 hours at a time. And so, to your question about what do we do with the business traveler, we welcome them to come for a group meeting at travel clinic and know exactly how to apply these products to the skin and clothing. There's permethrin insecticide spray, which is a very safe product. That's from a chrysanthemum plant. It's developed from a plant, and it's devised into a product that binds into clothing and bed nets and can last for months at a time to kill insects on contact without any harm to an individual. In fact, the ingredient is used as a medication to treat infestations and other formulations. So it's many people fear and worry about these products to combat the insects, but I think we have to try to, get the fact and the fiction straight for our own protection. As far as the development of vaccine, that's a wonderful question. Unfortunately, many times vaccines come to the point in progress, and then no further progress is made because of various levels of interest, or things die away. And so great science is done, we reach a plateau, and we never go to the finish line. And so there are some DNA approaches that are being thought through. And the other really interesting scientific approach is in Wolbachia infected mosquitoes, where they're injecting larvae of mosquitoes with this bacteria that can then somewhat sterilize the mosquitoes from further reproduction and pass that bacteria onto their progeny so that they no longer infect well to carry these viruses. A lot of interesting things can emerge if we put our heads together.
So I'll also speak both to the vaccine and the funding question. So in regards to the vaccine, so something that we saw with Ebola, so I personally was volunteering in Liberia during the Ebola outbreak and seeing over 100-some patients where vaccines were not going to help me then. What I needed was resources to support them through that. But we knew about Ebola being around since the 1970s. No work was going on in vaccines, though, until we get scared that the virus was coming here. The outbreak got so huge. So the same thing with these Zika and chikungunya and that sort of thing. Vaccines don't develop unless they affect countries that have the resources to actually make those vaccines. So we think yellow fever was a infection, mosquito-borne infection that caused huge outbreaks in the U.S. Back in the 1800s. We move along, we got a vaccine for that, so we get vaccinated against yellow fever if we're going to go to a country that now has that. So again, you have to have an outbreak for people to get interest and then give money to it, right? Now, caveat that with all this money now coming towards Zika, which part of that is because of the unknown that's there and the concern particularly for unborn babies. I think of the most infection that causes the most deaths in the world is TB. We don't have a lot of money going toward TB. It's not, everyone hears about it here and we think, oh, it's not here, it's not that common. We hear about Zika, we get very concerned. We're going to travel somewhere, it's going to be in our country or in our state. And so funding partly is due to, what's the media saying, what's the public fear that's there. Now, hopefully, with the funding that goes towards Zika, it's also going to be looking at mosquitoes and prevention of other mosquito-borne illnesses, so we can help with other diseases. But I agree, there is sometimes a disarray there with the amount of money that's given towards some things.
I'll just add about the mosquito repellents. There is a list that the CDC has recommended that are EPA approved, and those are recommended in pregnancy, even DEET-containing repellents for spray on, and that is the biggest message actually that we're trying to get out to women that live in those areas and have those that do actually have access. I think that's all I had.
Great. I wanted to, one second, please. I wanted to, and you may have come in late, just remind everyone, if you're interested in learning about biotech innovation around this problem, please come on March 2nd, because we'll have a second panel at noon with some local experts from the biotech industry who are working on genetically modified mosquitoes and also on vaccine development. So we will continue the discussion around those issues. So let's take a round of further questions. I think we have time for one, maybe two more rounds. Steve, did you have a question? No? Okay. Anybody who hasn't had a chance to ask?
Early, that's one of the reasons.
One second, let's
Hi. From what I understood, once a person has the Zika virus, they can no longer get it again. There's a kind of immunity that occurs after the first time. If a woman had the Zika virus and then becomes pregnant, will her fetus become immune as well, or is that a completely different, as a different entity, as a different organism, would it still be susceptible?
Do you want to take a bunch before?
Yes, it's back here. I want to let people have a chance to speak.
Okay. So far, the very mild effects have been discussed. Microcephaly has been discussed, but I wonder if you could talk a little bit about Guillain-Barre. Thanks. In connection with Zika.
Anybody else?
Yeah. What can be done to treat pregnant women that have been infected with Zika?
Okay.
Others, okay. If you want to follow up, we can. Is that okay? Anybody else? Okay.
So I'll address
Please.
the two that are not Guillain-Barre, since that's not my world. So related to maternal infection, it's true that the thought is that women are, or all people are likely to be immune. There is some thought, but that a first infection does provide immunity, although it's really not clear. I think that that's still sort of out there. There are certainly other viruses that there can be reactivation or reinfection, and I don't think we know for sure whether that's the case. Maternal antibodies, assuming that a woman does have them, begin to cross the placenta at about 16 weeks of gestation. How effective they are within a fetus is not clear because the fetal immune system really isn't developed yet. So it is, in theory, potentially protective if a mom has had Zika in the past, but it's very theoretical. And then yours, treatment, sorry. So there is no treatment. The reason, there are essentially two reasons that we are screening and doing serial ultrasounds. One is if microcephaly develops, we can offer women, if they're early enough, termination. The other is if the severity warrants it, we recommend that they be transferred to tertiary referral sites for delivery so that they can have high-level neonatology available to them.
Well, I think Dr. Reece said she was going to say something about the costs, and then you didn't in response to.
Oh, no, I had a response to the funding, how there is a lot of funding going into this, but so with Guillain-Barre, so we have seen that before with other viral infections. Post-viral infections, it's rare, but we have seen Guillain-Barre with that. So there are reported increased cases of Guillain-Barre in Brazil following a Zika infection, but we don't yet know the incidence or the rate to suggest it. But Guillain-Barre, it's a neurologic disorder where you begin with symptoms of weakness in your muscles that usually start in the lower extremities and then progress upwards. It can be supported through. It can take a long time for recovery, up to sometimes a year. That's really the only time that they've reported that hospitalizations have happened following a Zika infection is for Guillain-Barre supportive care. Okay, and there's different treatments that they do for Guillain-Barre, like IVIG or steroids, but that's also not my realm of specialty. As far as the cost of testing and this question of why are we not testing everyone who returns, one thing is who's going to do the testing, where's the resources coming from to run these tests? They're not cheap tests to do, and what labs are going to be doing it. So the CDC certainly is doing testing and recommending for all pregnant women who have traveled to that area to be tested. There's regional labs that the CDC is allocating to do some of the testing, and they're sending testing kits to states that have had a lot of, or an increasing, so Florida has had a lot of cases compared to the rest of the U.S., so they are getting testing kits that they can then do. The question of why we don't test everyone who returns is, A, it's a very mild illness, so what's the risk to those versus the cost of that test, particularly if the resources are limited. For men who are partners of women who may be pregnant, that's a different question. Should we test them? But the issue is we don't know how long it's shed in their genital tract. So if I test you at 4 weeks and you're still positive on your genital tract, when do I tell you to come back? How many times do I keep repeating that testing? And so I think until we have more research and answers to that, then we could then give better guidance as to safe sex or abstain from sex for this long, and then we'll test you to see if you're still shedding virus. But to think that we can repeat testing in so many people when the vast majority has a very mild illness that it's just an allocation of resources that not all states have, particularly in health departments.
And then back to the Guillain-Barre, most of the time that does resolve. It may take a very long period of time. Occasionally, the weakness progresses up to the respiratory system, in which case if you have to be intubated to support your breathing, it can be life-threatening.
Any other responses from the panel? We have one more, we have time for a few more questions, and we'll end at 12:30. Sorry, 1:30. Yes. Yes, you.
I had read that another side effect of this virus is blindness, something to do with the eye. And I didn't read it that carefully, and there were a lot of big words. So is that something that you're aware of?
So I read about that, but the eye is an extension of the brain, so it's not, I don't know the descriptions of cases per se, but blindness would not be an unexpected possibility.
Yeah, I'll just say that we're concentrating on microcephaly because that was the association that was made. There are lots of other reports of neural problems related to the virus. There's just only so many we can test for by ultrasound.
Right here, yes.
Knowing that the research is an ongoing process, is there any expectation that we can have around how quickly information might be able to be made conclusive, in particular with the efforts around microcephaly and maybe some of the other transmission types? And I recognize that obviously it's science and it's experimental, but just curious what, if any, expectations we might be able to have around that.
I'm sorry, expectations of?
In terms of timing as to when we might get more conclusive
On the way over here,
information.
NPR was having a discussion about Zika in which the head of the CDC answered that question from a caller by saying that within the next couple of months, anyway, we're going to know about a lot more about the link, at least the link with microcephaly. But for vaccines and things, I think, optimistically, we're in the 3 to 10 year range, and I think given the history of many other infectious diseases where vaccines have been promised for a long time and still haven't yet been produced, that 2 to 10, 5 to 10 is really pretty optimistic.
And this will be, we have one question here, and I think one more follow-up here, and that will be our last, those will be the last questions, please.
In regards to the blindness, my understanding was that was in fetuses, not in people that have the illness. Is that correct?
Correct. Yes.
Yeah, there were just first reports, I think, just came out in the journal. I think I read about it in the Times this morning, but it's among children who were infected. It's not amongst adults who had Zika virus. And again, amongst only a very small proportion of those, even with microcephaly, have these ocular issues at this point. But still, as with many of these other issues, a lot is still unknown.
In regard to the outbreak of microcephaly, are there other catalysts that might be involved in terms of that, particularly when you look at the dynamics of where the outbreaks have occurred in impoverished areas of Brazil? Are there other catalysts that you might want to look at in terms of that it's a stew of things rather than just one virus, or the interactions with other viruses?
Yeah, I think that's an excellent question. There may be co-infections. You could speak toward alcohol use or drug abuse and the incidence of microcephaly. I don't know if you have experience in that realm, and is that part and parcel of this whole outbreak as well?
Yeah, certainly. Drugs are actually not in general teratogenic, but alcohol certainly is, and so alcohol use could be another catalyst, as well as the other, as potentially co-infection. Could it be chick plus Zika or dengue plus Zika? absolutely unknown at this point in terms of whether or not that is an issue. And the cross-reactivity, one of the things that they will be doing is collecting dengue exposure, history of yellow fever, vaccination. All of those things will be on all of the case report forms as we screen pregnant women. And so the hope is that they will actually gather some information about other things that may be traveling with it.
And I guess one additional comment is if someone were to return with a febrile illness and they're not being tested but likely have Zika, the recommendation is to not use any medications that hurt your coagulation, like aspirin or Motrins or ibuprofen-type drugs, because that may induce further bleeding. You may also have dengue infection, which is associated with bleeding. Zika doesn't seem associated with bleeding, neither is the chikungunya virus. But for that dengue risk, we ask you to avoid such treatments.
Which we luckily don't use in pregnancy anyway.
And the beauty, if we were able to tease out all these diseases, is that the chikungunya virus, in outbreak form also in Brazil, has left many people with a severe bilateral arthritis similar to rheumatoid arthritis. And so how to approach people and their treatment when they really do need nonsteroidals. And some doctors have been using methotrexate and other advanced rheumatoid arthritis treatments to try to get ahead of that in people who've had months and years of arthritis from this.
Are there any last comments that the panelists would like to offer? Anything that we haven't addressed that you think people should know about?
Yeah, I mean, I think the thing will be is that this will continue to be updated, I think, pretty quickly as more information comes out, particularly with the new funding that's coming out to the CDC to actually start doing these transmission studies and doing this epidemiology studies, both here in the U.S. and helping out our U.S. territories as well. We haven't talked about Puerto Rico and U.S. Virgin Islands. Certainly, they will have a lot of local transmission cases, and so as part of that, the CDC is kind of not isolating, but focusing on them as well in preparation for the spread to those areas. So I would stay tuned. I think there's going to be a lot.
And I do think the increased level of emergency that they declared yesterday from the
Higher
CDC
up,
that will actually help quite a bit with and they actually expressed that they needed it for scale up. They cannot scale up the testing without that, and so that actually will help a lot.
Okay, well, thank you very much. Please join me in thanking our expert panel. Very informative discussion. And those who are interested, come back on March 2nd at noon.
Yeah.